But yes, we look forward to this panel discussion with our esteemed guests. And I will right now turn it over to my colleague, Dr. John Buchheit, who is an associate professor at the VCU School of Pharmacy. He also serves as our PGY2 Ambulatory Care Residency Director. And without further ado, I'll turn it over to you, Dr. Buchheit.
Thank you, Dr. Salgado. I'm really excited to be here today. We have a really outstanding panel that's going to provide lots of really good perspectives on billing and from their practices, from past experiences. So I'm going to give a brief introduction of our panel members here, but they are definitely going to fill us in on a little bit more on what they're doing at their practices, keeping in mind that they come from experiences before their current practice too. So we're really excited to have members from both community-based practice uh, partners and then also clinic-based or ambulatory care pharmacists as well. So without further ado, again, Dr. Salgado, I'm John Buchheit, and I will be moderating today. My main practice site is Crossover Healthcare Ministry, where we have about 25% of our patients with Medicaid. The rest are uninsured. So we are doing some billing practices there as well. So I'll be leading the discussion today. But for our first panel member, we have Dr. Ashley Flagg. She is from Buford Road Pharmacy, an independent pharmacy, and she serves as the Director for Clinical Services. We have Dr. Lupe Govia. She has multiple roles, wears multiple hats. She is a Director of Pharmacy and Clinical Training at Walmart Health and Wellness. She's also a PGY1 Community Pharmacy Residency Site Director, and she's the Program Director for Pharmacy Technicians University. So these two members represent our members from the community-based setting today. And then we have three members from our clinics, our ambulatory care setting. We have Dr. Abby Lennon. She's a clinical pharmacy specialist. She practices at Inova Bariatrics and the Bariatrics Clinic. And we have Dr. Zakia Woods, who's an ambulatory care pharmacist from Riverside Health System. She's an ambulatory care pharmacist who practices in a heart failure clinic and a family medicine clinic. And each of these members will tell us a little more about their roles. And then we have Dr. Keenan Ray. She's an ambulatory care pharmacist with UVA Physicians Group. She's also a co-leader of the Pharmacy Practice Advancement Group for ambulatory care pharmacists in Virginia. We're excited to have all our members here today. So I think at this point, I'm going to go ahead and turn it over to Dr. Flagg to tell us a little bit about what you're doing at your practice site and clinically, but also what are you billing for with regarding Medicaid?
Hi, good morning, everyone. Thank you so much for having me on for this discussion. So we have quite a few statewide protocols implemented at our pharmacy. We just started up test and treat for COVID, flu, and strep. But before that was implemented in the fall, we've done the TB screenings, and we've had that implemented for a little while. The protocols for vaccines for children and adults. And naloxone, some things that we're hoping to get on board in the future, hormonal contraceptives, the smoking cessation. We don't quite have the patient population for HIV, PEP, and PrEP, but not to say that won't change. So also something that we would consider as well. Right now, the majority of our services are a cash-based model. We are still kind of in that credentialing process, trying to get those contracts to bill Medicaid. We have a couple of contracts, but we haven't had any patients come in yet. So we are able to bill a few of those MCOs, just haven't had any interest yet.
Thank you so much. Yeah, it's a challenge to get the Medicaid billing process started. Once it's started, it's a little bit more seamless, but it is there are a few steps along that process that we'll hear more about today. So, Dr. Govia, you want to tell us a little bit about your journey and what services you've implemented throughout your career and what you're billing for Medicaid?
Yes, good morning, everyone, and thank you for having me. So at Walmart Pharmacy, and we operate across all the states, but in Virginia in particular, we're offering services for blood glucose, cholesterol, A1C testing. We've been doing that for quite some time. We offer those services for out-of-pocket cash pay. We have also added on testing and treatment after the pandemic. We actually started billing Medicaid just April 1st, so just this past week for COVID testing specifically. We are also, and that's through some commercial payments, so commercial billing, not necessarily through Medicaid, and we'll talk about the challenges there and why. We are also offering hormonal contraceptive prescribing, and that program did just go live with billing with Medicaid on April 1st. And then we're also offering HIV screenings for HIV, not diagnosis, but screenings. And then we will be adding on PrEP and PEP as soon as we're able to with the expanded scope of practice.
Oh, that's exciting. So I'm glad we had our presentation today so we can make the big announcement for April 1st. That's really exciting. Have you had any feedback so far? I know it's only been 4 days. How has it gone?
I don't think we've had any claims yet. And back to what Dr. Flagg mentioned, it's really, I think one of the top things is going to be awareness in the community. And so making sure that patients understand that they can come to the pharmacy to do this. We've got plans though. Good
to hear. Yeah, I think that is going to be an important aspect. And one of the reasons why the Center for Pharmacy Practice Innovations having the Medicaid Summit, presenting at local conferences and having this presentation today. Awareness is a big deal, and support and resources. It's a whole team and a whole group as pharmacists in Virginia that we need to work together to use these services and then get them to our patients. So I think you bring up some really great points. All right, moving on. Dr. Linden, would you like to tell us a little bit about what you do in your practice and what you're billing for in Medicaid?
Yes, thanks, John. So I'm Dr. Abby Lennon. I practice currently at Nova Bariatrics. I provide various services under a collaborative practice agreement, so really chronic disease state management with an emphasis in diabetes, but also hypertension, hyperlipidemia, smoking cessation as well. And so I practice with both our surgical team and our non-surgical weight management team as well. I have worked under a collaborative practice agreement since I started at the clinic, and then I have been billing for pharmacy services in the state of Virginia since 2019 on and off at various clinics. So I was able to do that in my residency as well. And we did bill Medicaid then, and I currently also bill Medicaid now. I bill under the Incident 2 model. So Incident 2, the supervising physician that referred the patient to our service. So really utilizing the CPA and then also being able to bill Incident 2 in that model.
Great. And so how long at Inova have you all been billing Incident 2?
So we just started billing as a pharmacy team in the fall. So I was lucky enough to be able to be one of the pharmacists that brought billing to Inova. It certainly had its challenges, and we can talk about that a little bit later. But we just started billing in the fall of 2024 and are just now starting to get some of the reporting. And I can talk about that a little bit as well.
That's super exciting. And just for the audience members, the legislation that allowed pharmacists to do this was passed in the summer of 2023, but there was still a waiting period, which is actually pretty short for Virginia. But we really got really firm guidance in 2024. So to already have started billing with CPAs 6 months after that guidance had come out is really impressive, and so it gives us a wealth of information to talk about today. And then next, let's move on to Dr. Zakiya Woods. Tell us a little bit about your journey and what's going on with your current practice role and what you are billing for Medicaid at this time.
Yes. So my current practice role, I work within family medicine practice within one of our medical groups for Riverside Health. I also work within our Department of Cardiology, as mentioned, as well as through the Department of Internal Medicine. I also am overseeing a diabetes telehealth population health initiative for a different medical group within our practice. For right now, when it comes to billing, we've had several conversations of it. I will give just a preface background that I have a wealth of experience billing in the past from a previous part of my career where I billed for remote patient monitoring. I did incident 2, chronic care management, annual wellness visits, transitions care management, diabetes self-management education. I was very clever with my billing and working with the medical directors there because my goal was to, since it was an independent practice, for me to bill enough for me to pay my own salary, and I was able to successfully do so. Having said that, here at the health system, even though I come with that knowledge, it's very new. But I have a lot of attention for those that are very interested moving forward. Our leadership has actually approached us to see what we can do more. So far, we've been billing primarily procedure codes and low-level incident twos that will be expanding. We are having active conversations around that at this time. So we're really excited to really implement more codes based off of pharmacist capabilities, based off of previous successes.
Great, that's outstanding. Yeah, so Dr. Woods has a wealth of experience in a lot of different settings, billing different types of insurers. So we're really looking forward to your information you're going to share with us today. So thank you. And then let's move on to our last panel member, Dr. Ray. Tell us a little bit about your process right now as you're working through trying to implement some value-based services and also trying to implement new services for billing Medicaid.
Yes, so at UVA, pharmacist services aren't new. We definitely have a lot of embedded pharmacists working on mostly cardiometabolic conditions. A lot of them have a collaborative practice agreement for those offices. Again, as you said, we have not successfully been billing yet, but we do have a lot of steps in the works to try to move towards that and pursue billing. We are working on the credentialing and privileging part of that right now, as well as leveraging state protocols for some of those independent services as well. And my specific role, I am working a lot with a population health sector and helping improve those value-based contract measures. Again, there is a lot of overlap with those cardiometabolic conditions, so we have some opportunity for expansion of services in that department as well.
Great, thank you. As we can tell, and I think I should importantly note that a lot of the conversation we're going to talk about billing today is more in a fee-for-service model, but this is not the only type of model that's out there for practice. We definitely need to be focused on value and quality as well. And so while the focus is today on fee-for-service, which I think is important as we move into different healthcare models that pharmacists are able to bill these codes, we do need to still keep in mind, never lose sight of the quality of care that we offer and the value of the pharmacist. So I think Dr. Ray is going to be able to help us out a lot with that today. All right. Just want to, as a reminder, if you have any questions, we are going to have a short Q&A session at the end, but feel free to go ahead, as Dr. Salgado said, to put any messages in the chat as they come up, and we'll do our best to try to integrate them into the discussion today. We have some questions for the panelists that we're going to be asking, but we definitely want to make sure that we're meeting the needs of our audience members and the questions they have today too. So our first question today that I think I'm going to go ahead and see Dr. Govia. Can you tell us a little bit about the stakeholders that you needed to engage in your organization? I know you have been throughout the United States and then Puerto Rico making some changes, but tell us a little about that process of where you went from the beginning to engage some stakeholders into getting some clinical processes changed.
Yeah, so being a large organization, you can imagine, and I think it doesn't matter the size of the organization. If you're in a health system or in a clinic, it's probably going to be very similar, but there's several stakeholders kind of centrally from a corporate perspective. We have our practice compliance partners, we have our legal partners, we have technology partners that we have to work with. Generally speaking, it's always going to be our practice compliance and legal partners to say, hey, we're trying to do this. What are the things that need to be true in order for us to get there? Are we able to provide these services in this state? Or what are the states that we can do these things in, and how can we? Operating, in all jurisdictions, there's a lot of variability. And so really getting a good understanding of, if I'm doing COVID tests and COVID, flu, and strep testing, for example, in Virginia, it may not look exactly the same as it does in a different state. And so really getting very granular about what are the services that we can provide, can we act on those results of whatever it is that we are doing? So getting really good clarity around the practice environment and from our practice compliance partners is generally our first step. Secondly, legal, again, making sure that we have all of the legalities in place to be able to administer the services and how we can go about that. Then thirdly is generally where we start working with our product partners, our technology, and trying to figure out how are we going to administer these services in our stores. Because we are so broad, we want to make sure that we have a process in place that is standardized across the board. So even though there is variability across states, we want to make sure that we are creating an environment where our pharmacists understand exactly how to document the service, what is the workflow supposed to be, and trying to make it as simple as possible for our pharmacy staff, because ultimately they're going to be administering the service. And so we generally control all of those things. There's in the new environment, there's very little that we do on paper these days. We try to really add in those the digital tools to ensure that they're able to just work through a protocol, if you will, of checking the boxes and understanding exactly how they're going to administer these services. We also work with our billing partners and our contracting partners. And so they are the ones that are, kind of in tandem working on getting contracts. What is this going to look like? Are we going to be offering this for a cash pay model initially? That's generally always going to be the case as we are trying to solve for the contracts and the credentialing and enrollment pieces. But those are all working in tandem in the background. Once we are ready to launch the program, if we have the ability to do that, then it's going to go out for cash pay. And so at that point, the other really big and probably the biggest stakeholder would be our operators, and operators meaning our field leaders, our pharmacists in our stores, and ensuring that there's an understanding of what we are expecting them to do. In my role, I usually come first with kind of the clinical training component of things. And so ensuring that we are explaining and messaging to our pharmacists that we are going to be delivering these services. This is the expectation. So there's generally going to be some clinical training that we provide for them. And so there's a timeline that we essentially build into. There's clinical training, there's operational training of these are the things, for example, with test and treat. There's the hands-on component of knowing how to use the devices that they're going to be using, how to do, swab collection, et cetera. So there's sort of a layered on approach to the training component of things, because it's not just the clinical aspect, but then it's also, are there any devices that I have to use? And then last but not least is kind of the full picture of this is how it comes to life at Walmart. So it's the workflow pieces, this is how you engage the patient, this is how you document, et cetera. So I would say the biggest stakeholder is really our field pharmacists, and ensuring that they understand why this is important, ensuring that they are walking through the steps and completing all of the training that is required. We also have a marketing component to that, and I was talking about the awareness piece. And so at the same time as we're working with the other stakeholders, there's also a huge marketing component that we bring to life. And that generally, in our environment, we sometimes have some soft launches is what we call them. As we kind of test out the process, make sure that everything's working correctly. And then our marketing partners, we may come really strong after, we've tested out everything that it's working appropriately. And then we put out a lot of marketing to ensure that there's increased awareness in the communities as well.
Wow, that's a lot of really great information. And I do think that's a really good point where these items come up in conversation. Whether your practice site has one pharmacist, maybe three pharmacists, or a whole organization, there's a whole different aspects of getting people enrolled, getting people practicing in a standardized way. And so it's really nice to have that perspective of, I have a large group of pharmacists in Virginia that are able to offer these services. And Do want to just make sure I clarify, Dr. Govia, are you using CPAs in statewide protocols or only statewide protocols, or can you tell us a little bit about that?
Yeah, we primarily operate with statewide protocols. The states that we generally don't launch services into is when we talk about a 1-to-1 ratio, right? Where you require like a pharmacist to patient to physician CPA relationship, because those just become very difficult for us to administer in our practice. So we generally have statewide protocols that we can lean back on, or if there's a statewide CPA, those would be the ways that we practice.
So that makes perfect sense, and it's nice that we have these different avenues of scope of practice that we can practice in as pharmacists to make sure our model of care is included. Definitely also wanted to hear from Dr. Lennon. Could you tell us a little bit about the stakeholders that you had to engage as you were in 6 months billing after the new processes came in?
Yeah, absolutely. So, again, for us at Inova, most of us are practicing, actually, I think everyone is practicing under a collaborative practice agreement that is billing for pharmacist services. So, the biggest or the first stakeholder, I suppose, is getting your physicians and other providers on board with signing and agreeing to work under a collaborative practice agreement. So my particular clinic had not worked with a pharmacist before, so I kind of started there and gave a little bit of an in-service on what that can look like, the types of services we can provide, and kind of targeting some of those low-hanging fruit to get my foot in the door. So smoking cessation is a really big service when it comes to our surgical population. So that was kind of an easy introduction for some of the surgeons to get on board. And then from the non-surgical standpoint, offering diabetes management. So I also am a CDCS, so being able to help care for those folks as they are going through their weight loss journey. So we really had to start there, make sure that the collaborative practice agreement was in place. And at Inova, we also have been trying to standardize the collaborative practice agreement a little bit more. Each of us had a little slightly different version of it, and we realized that probably wasn't going to be the best going forward in trying to implement billing. So we have revisited that and standardized that so that it could be implemented kind of across the board in a lot of different clinics as we start to expand services. After that, we really had to work with the revenue integrity, which is like our compliance team, and make sure that they understood what we were trying to accomplish. We had a wonderful point of contact there, but she has not worked with pharmacists before, is not of a pharmacy background. And so really, I think that was probably our biggest hurdle along the way. We started by bringing in examples from other institutions. So we had some examples from VCU, from UVA, not only from like their CPA, but the types of services that they were implementing. And so we were able to kind of show what has been done before. And then I also brought in some of the smaller like models that we have done in the past. My residency was at some smaller independent clinics, so we were able to use that information as well. And then really, I think what started to move the ball was last summer when DMAS kind of was very open and published some really helpful resources on their website for implementing pharmacist services. Particularly, they published an FAQ document, which really outlined very clearly what could and could not be done under a collaborative practice agreement. And so it was very straightforward. And I think once we had that, our compliance team was much more quickly moving to get the ball rolling, so to speak. So that really helped us a lot in just outlining, again, that folks practicing under a collaborative practice agreement are able to bill Medicaid and able to bill at a level that's appropriate for that service. So that definitely helped. And now currently we are working with our clinical business team, again, on the reporting side of it. So we've been billing since the fall, and just a couple months, well, actually just last month in March, we were able to get kind of our first report for the codes that we billed and what the actual reimbursement was from each of those different payers. So we are still working on that. I think it's been a little bit more of a challenge than we were anticipating. Just making sure that, you know, from our standpoint, we just want to know if we build this code, what does the reimbursement look like? But it's a lot more challenging on their end to actually run these reports in Epic. So we've been working with them and kind of meeting on a biweekly basis to really refine and make sure that from our standpoint, we have a lot of clarity so that we can further expand services out and kind of start looking at some of the other areas of practice. So for me, you know, I really want to make sure that we're getting reimbursed for CGM interpretation and education and things like that. But that has also been a challenge that we're still working through. So I think for us, the biggest things is implementing your CPA with your providers, getting your compliance team on board and making sure that they also understand the types of services that you want to provide and what that might look like. And then making sure your documentation is in place as well. So we were able to work with them in our note templates and different things in Epic so that all of that was in place. And then finally, making sure that we are actually getting reimbursed for the services that we are providing. And so working with our business team as well.
Oh, that's great. And I just want everyone to know in the chat, I shared the document that Dr. Lennon was referring to, the DMAS frequently asked question document. Again, if you need a document to show to your compliance and billing teams, that's a great one to use. And so thank you for highlighting that today. So I think when we talk about billing, there's scope of practice and billing, and they're separate, but it's really hard to untangle both, right? And so I do agree with Abby. The first step is you have to understand what clinical services you can offer in that ambulatory care setting, and then trying to build that CPA. I don't have the link, but there are some updated regulations to CPAs in Virginia that just came out. So I encourage everyone to go look at those. So there's been some changes, just some slight changes, but definitely some modifications into some of the language in the CPAs as we're all updating our collaborative practice agreements. Thank you, Dr. Lennon. Dr. Ray, I was hoping you could tell us a little about your experience talking to stakeholders. I know with a value-based approach, you're having these conversations with a lot of different leaders at your organization. So can you tell us a little bit about your conversations?
Yes, so obviously that's something that we're pursuing now at UVA, and I also have a lot of experience of hitting barriers and discussing with different stakeholders at my previous position at Augusta Health as well. And obviously in the practice advancement work group, we get a lot of members sharing their successes and their barriers, because that is the whole point, is trying to find those answers that someone else might have figured out in order to facilitate that united advancement. So I agree with what Dr. Lennon and Dr. Gouveia have said so far. Clinic stakeholders, again, your providers, your clinic supervisors and managers, they need to be able to understand the opportunity there and that scope of practice for pharmacists. Again, especially with those that additional scope of practice from a collaborative practice agreement. The department stakeholders as well. Again, this might not be something that I hope it is, but it might be something that your pharmacy department, your director or chief is not currently aware of those opportunities or what it would entail to pursue that. So it's good to always have them on board before you further expand your discussions with other stakeholders. But again, the compliance department was probably the biggest one for me when I was at Augusta. And again, they're ensuring that the organization follows all of those rules. Their main goals are to protect the patient, prevent any type of legal issue, as well as fines. I know that was their biggest concern, that if we do this incorrectly, we're kind of have to pay a lot of voluntary repayment back. And that's something that they were really scared. I think they were very interested, but that financial worry really kept them from pursuing that. Again, revenue cycle, that's something that I know even just working in our population health space at UVA, I think one of the examples is for AWV, you have a nice difference in when you can do the next AWV for traditional Medicare versus Medicare Advantage. And again, that's outside of Medicaid, but it's just an example that they didn't understand that difference either. They kind of grouped them all together. And as a lot of our panelists have said, there are some nuances to different plans. So that's something that they might not even be aware of, that a pharmacist, again, working under a CPA might be able to have that type of template, that coding, certain codes that they can use. They might automatically flag it as something that cannot be sent if they aren't aware of those capabilities. And lastly, sometimes, again, I think Dr. Lennon had mentioned this, like the templates that you might see within your EHR might need to change. There might be some limitations there. So I would definitely, if you can, again, having a lot of these stakeholders at the same meetings once you get the ball rolling would be really helpful so that everyone knows what page we're on, who is the next step, what are we waiting on. And sometimes you even get the privilege to get a seat to speak with C-suite, which again, I think is sometimes rare, but is possible. So again, having a lot of these stakeholders from the clinic, from compliance, from revenue cycle, credentialing and privileging team, again, is something that we've discussed as well already, is that you have to make sure that the pharmacists are qualified and authorized just like other providers at your healthcare institution to provide these services. And there are a lot of moving parts, a lot of different stakeholders, but again, trying to get them all on the same page is sometimes a difficulty, and they really ultimately don't know what they don't know. So it's going to be a lot of education, as Dr. Gouveia and Dr. Lennon have already stated.
Yeah, thank you. That's some really good advice. And this is really important as far as one of the initial steps for moving the ball to get to that process of billing in your clinic. So I'm going to move on to the next question with Dr. Woods and Dr. Flagg, but please, if there was some other information or pearls that you'd like to share about stakeholders that you had to meet with while you answer this next question, please feel free to add that. So since we're still kind of on the ambulatory care page, Dr. Woods, do you want to start us off with talking a little bit about the infrastructure that you had to put into place to get, or as you're putting into place, as you're getting ready to start billing Medicaid, or in past experiences that you did put in place?
Yes. So I'll start with past experiences, and I'll talk about current. So previously, again, I worked at a small independent practice in Norfolk, Virginia. They were not looking for or were aware of ambulatory care pharmacists. So I approached them with a business plan post-residency and explained the different services that pharmacists can do. I want to pause and say I think that's one of the biggest pieces. I always tell my APPE students and my residents that ambulatory care is 70% clinical work for 20% entrepreneurial. We have to make sure to upsell and advocate ourselves. We have to be able to not just talk about, talk the talk of what we've learned in school, but we also have to be able to really show how we can contribute to the practice. And you have to know your audience. Is it outcomes or is it numbers? What is it that they want to hear? So for an independent practice, they did not have a budget for a pharmacist, but with the billing codes and the billing structure that I presented to them, we talked about workflow, which I created a workflow as well. I'm a very PowerPoint workflow fanatic, which I think most of us are as pharmacists. We're just that type of character. They were very open and willing to utilize the codes. Having said that, because it was an independent practice and I wanted to make sure that I was doing everything that I said I could do during the meeting, which of course, I knew it in theory I could from reading and from various articles and previous examples, but I had not done it in person at myself. So I was very cognizant and very focused on the reports to make sure that I was following the numbers, which claims were covering what insurers paid for which services. So that when I was, again, focused outcome, but focused on outcomes, but whenever I would see a patient, I would look at their insurance plan and I would be aware of, okay, I'm still going to offer the same services, but these are the codes that I'll utilize during their care. Because again, we didn't want to adjudicate for anything that wasn't going to pay. So that was very important for us. Once I moved over to Riverside, again, it's new and novel for health systems to have pharmacists billing to the capacity that I was billing. And I also will say I was in my own bubble. I didn't realize, it wasn't until I got to Riverside that I didn't realize how many people were not billing to the capacity that I was. So I was very outcomes first focused in the beginning. And when we started our service, I am also a PGY1 community residency coordinator. So we started our clinic at a family practice site. And we were talking about, generating revenue during that time frame. Since I am a CGM specialist, I'm also a CDCES. We used a lot of the interpretation codes to start off with, and again, follow the numbers. When I actually show that information to leadership, it really wasn't about the reimbursement because those CGM interpretation codes may not bring in the most. It certainly does not pay for a pharmacist's salary. But the point that I wanted to drive home was these bills are going through, these adjudications, these claims are going through. I think what was interesting for us this year is that many times we're the ones going out and advocating for ourselves, whereas at least for this year, 2025, and I just want to brag on my health system for this, they came to us and said, hey, what can we do differently and how can we best support you? And is there a way that you're able to generate revenue? So I was able to crack my knuckles and I came in with everything that I could to share everything about where we're going. So we're having very active conversations around expanding, code by code so that we can do the same thing. I did same practices, billing the codes, following the numbers, ensuring that the claims are going through the way that we understand so that we can make sure that we are not unfairly billing patients, but at the same time generating revenue when there is space so we're not leaving money on the table.
Oh, it's super exciting. And Dr. Salgado, I'm sensing maybe for many of our panel members, future CPPI seminars to hear updates on all these programs that everything's being implemented. So thank you, Dr. Woods. And yeah, we look forward to hearing all the great stuff you're doing here in 6 to 12 months. So can't wait to hear. And Dr. Flagg, tell us a little bit about the infrastructure that you had to put in place, and if you had any information on stakeholders you had to engage as well.
Sure. So in terms of things that we needed to add into addition what we were already doing, so we needed a way to actually bill for the service. So contacting a medical billing provider, and what else were they able to offer us? So the company that we are working with are also helping us with our credentialing process, and helping us get those contracts. They also have a really nice platform where we're able to document specifically our test and treat services for COVID, flu, and strep. So whenever anyone thinking about doing this, when you're looking into the technology that you want to use, also consider what other things are they able to provide. Are they just going to do the medical billing piece for you and you need to gather the rest of that on your own? Or do they have some other things in place that can help supplement, kind of take some of that extra work off of your hands so you can focus on actually providing the service? So with that, it's a totally separate platform from what we have for all of our other services. So it's been a little bit challenging because our other pharmacists or staff pharmacists are very used to going to one place to document all of our services. So making sure they know that they also need to document on this other platform. And with that, the company that we are using are also involved with several other states. So their EHR is not Virginia specific. It's very broad, so it may not have all of the components specific to your state. So I had to, between myself and the resident, I'm also the site coordinator for PGY1 community residency with VCU. So between myself and the resident, we had to make some checklists and cheat sheets just to make sure that our staff were asking all of the things that were required for the Virginia statewide protocol and documenting that in the EHR, just to make sure that we're covering all of our bases and not missing anything. On a practical level, since we started the medical billing process primarily for test and treat, also wanted to make sure that I had a separate area for our sick patients and kind of keep them a little bit separate from our well patients. So that was a little bit of a challenge, finding a separate space to kind of segregate everybody. But it seems to be working out fine. So we are doing the service as a cash-based model. So we have seen a few patients utilizing that model, haven't billed anyone for Medicaid yet. So those are some of the big things in terms of infrastructure. And it's a long process. So having patience and just trying to communicate often to kind of see where we are in the process. In terms of other stakeholders, we recently came under new ownership. So kind of reselling this business model to the new owner, what was going to be the benefit of doing the services, what can we expand on after we've gone through this whole process, and hopefully continue to grow in seeing patients and earning the revenue. So that was something, you know, they're very, sometimes people are very focused on the business aspect, like, are we going to be digging ourselves a hole? So also very important. So really presenting that business plan. Here's the number of patients that we need to see, and do it on a very granular level and kind of sell the service again. So that was fun. And a redo of residency, it felt like doing that business plan. So
Mhm. Yeah, thank you so much. So we've heard from Dr. Woods and Dr. Flagg. Entrepreneurship is a really important skill as we navigate through all these processes, and thank you for both emphasizing that. And it looks like Dr. Ray has a comment as well. So go ahead.
Yes, in addition to what Dr. Woods and Dr. Flagg had mentioned, I want to emphasize or encourage pharmacists or departments that are interested in implementing billing is that if you've already done a lot of research and our documentation is going to have to change, you can start changing that documentation ahead of time. I know that's what we did at Augusta Health is, again, we were a while away from that green light to actually start billing, but I was making sure that our documentation was compliant from whenever we first realized, hey, we need to add in the time component. Because if anyone has read that FAQ from DMAS, you're going to have your medical decision making or your time-based component for which codes you're going to be picking. So we had the time spent with the patient, time spent on documentation before and after, care coordination. Having that in the note, we made sure we were getting official referrals from our providers there because I was only working with one primary care office at the time, and we did a lot of verbal referrals. So if anyone's going to be looking through the patient's chart, they're not going to see that. So we made sure to get official referrals, and also adding in like the last appointment in our smart phrase, the last appointment with the provider, the last time the provider reevaluated appropriateness of pharmacist services, so that we tried to keep that, again, depending on what the service is. The patient might see the provider every 6 to 12 months in order to keep seeing the pharmacist, and again, reevaluating appropriateness for those pharmacist services at least yearly. So that's something that you can do pretty easily, again, with smart phrases or smart text, that you can get some of that already in place so that when you do get the green light, you're ready to go. You're like, we can start tomorrow. Like everything else is in place and ready to go.
Wonderful recommendation and a good point. So if there's some processes that even if you're not billing that need to be changed before billing, go ahead and start implementing them as you're presenting these to leadership. It's nice to say we are already following these processes, and it'll be a seamless implementation, we hope, at least. So that's great. Do any of the panel members, I know Dr. Lynn touched on a little bit, but as far as I've heard a little bit about for infrastructure related question, making sure that your claims are going through successfully. So does anybody have any perspectives on how that's going with your institutions, like a process? Do you have a team member that helps you with that? Are you getting reports for that? Does any panel members have anything to add to that portion of the infrastructure? Go ahead, Dr. Govia.
Yeah, on our side, we have an entire team. I was talking about the different stakeholders. And so we have an entire team that is dedicated to looking at the claims as they're going through, and then keeping an eye on them to see if there's reimbursement that actually happens on the backside. So the revenue cycle management team is generally the one that manages that. My understanding from other billing that we've done in other places for Medicaid and Medicare in particular is that it generally takes a very long time to see the reimbursement and get the payment back. And also that there's also a lot of hand holding at times with claims that get rejected, and then having to go in and really understand why those were rejected. So I think, whether you're in a small setting or in a large setting like us, having somebody that is really dedicated to doing that, just like Dr. Woods mentioned, is really critical to make sure that you're actually seeing the outcomes that you expect.
Yeah, great. Thank you for sharing that. And because we hear that, from billing and revenue generation compliance, that we're afraid we're going to not get paid for these services. So that is helpful. Dr. Woods, did you have something?
Yes, I partner with our billing department as well, and I can get reports upon requests. I do recommend for anyone that's starting a new clinical service within their respective practice to have specific champions, and a billing champion is huge. Not just to talk through the code so they can better understand, but so that they can, give you the numbers so that again, when you're billing, you know exactly which codes to bill, what will work, what won't work. Is it too soon? Because again, if it's a procedure code versus an incident two where it's per encounter, has there been enough days in between before we're billing for something again? So, you can work and partner with them and they can help you better understand, or if there's any gaps that you can close for them for knowledge. It's very impactful and very helpful.
That's great. I think that's an excellent point, especially as you're implementing these newly implementing these services, to make sure that you're getting some feedback pretty early is probably a really good suggestion for those who are implementing those services. Thank you. All right. Next up, we do want to hear a little bit about, I know the services are new, but have you been able to expand your current offerings as for pharmacists and these clinical services, or do you hope or expect to expand these offerings as pharmacists or your pharmacy team members? So maybe Dr. Govia, do you want to touch on that?
Yeah, for sure. So I really liked, I can't remember who mentioned, having other departments coming to you and saying, hey, what can the pharmacy space do? And how can we create some additional either revenue or provide additional value to your member population? Similar in our space, if you know Walmart, we're part of a big box. So pharmacy is one component of the rest of the store. There are different reasons why we would expand on services, but that is one of them. Sometimes it's the rest of the box, so the store management, and we call it Division One at Walmart. They sometimes will come to us to say, if we know that there's either a competitor, for example, coming into an area, they will come to pharmacy to say, hey, what can you do to help us and create some stickiness, is what we call it, to ensure that we continue to keep our patients here at Walmart and provide those services. So that's essentially how we actually started with blood glucose, cholesterol, and A1C. This was back in 2016. We were providing those services in 4 stores in Texas. And then on the East Coast, there was just really wanting to create additional products that we could offer. And so that became just a natural progression of it. So that was the genesis, if you will. In terms of expansion beyond that, I talked about various stakeholders, but really number one is your executive leadership, right? So your C-suite, and making sure that you have alignment on which services you're going to really lean into. I mentioned a lot of things. The big areas for us right now are immunizations, and we've been doing that for quite some time. But immunizations, testing and treatment, and hormonal contraceptive prescribing are really the big buckets that we're really trying to focus on, with HIV screenings and those other PrEP and PEP and long-acting injectable administration in some areas, but those are in smaller pockets, generally speaking. So really the wanting to look for additional services is usually based on, what is going on in the community, how are we going to respond to the community needs. That's how we a lot of times identify, for example, HIV, and where are we going to add additional HIV products. It's if the population and the demographic in that area really is an area that would benefit from that, then we would bring it there. So I would say there's a little bit of an art to it to figure out what services you're going to expand and how much you're going to lean into those and really support them. And yeah, I think that's generally, and then, well, of course, the revenue piece is always going to be important, right? Like, what is the potential with revenue? I think, and we mentioned it earlier, we generally launch in a cash model. There's a lot of hesitation, generally speaking. Now, if you're in a small community independent pharmacy, for example, you're probably already bought into that concept as the pharmacist, right? If you're the one spearheading, like Dr. Woods has mentioned, Dr. Flagg, you're already bought into the idea, so you don't really have to do a whole lot of convincing in that setting. For us, it's a little bit different because we have several different pharmacies. The decision gets made corporately, and then we push the message downward. And so making sure that you are identifying what the motivation is for every individual, right? And having different ways of really getting those people to adopt the service, accept it, and then be able to speak to it in a way that it makes sense. Some people are motivated by the business and, you know, bringing additional revenue, et cetera. And so understanding who your audience is, because others are motivated by, you know, they went to pharmacy school to do good for people. And so making, you know, tying that back to this is how you're impacting your community, and this is how you're adding on additional ways that you can care for your patients. And so that's generally how we are able to also just ensure that we're incorporating the change management component, what we call it, to ensure that the service is actually successful, because we can launch a lot of things, but if the pharmacists and the technicians are not talking about it in the pharmacies, then it's not going to happen.
Okay. That's extremely helpful. My only follow-up question would be you mentioned revenue generation, and that's a big focus for sure. In your experience, as pharmacists have been expanding these services in your practice, what kind of even if there aren't more pharmacists, do they get more resources? Are there more technician support? How, as you're offering these new services, how does the revenue generation fall on support for the pharmacists to add these services?
Yeah, I think so. From a large corporate standpoint, a lot of the things that we're doing is to try to centralize all of the things that we can do. So, for example, dispensing, right? Getting the prescription ready, filling prescriptions, et cetera. That part of it, we're really focusing on centralizing that and bringing it from a central fill perspective, so that we can remove that workload from the pharmacies. You know, your chronic medications that you get on a regular basis, those are very easy to centralize because we know that patients are going to need them on a monthly basis. And so really pushing more for centralizing anything that we can. We have a central MTM team as well that can provide and do like CMR centrally. And so removing a lot of the things that can be done centrally and letting and really leaving the time and the resources for the staff that's in the pharmacy to do the things that they have to do in person, right? You can't put an immunization and you can't provide that centrally. And so making sure that we have the time for the additional services, which is, you know, the new scope of practice, expansion scope of practice. So centralizing anything that is possible is really the strategy there.
Great, thank you. That's really helpful because I know pharmacy workforce in Virginia and nationwide has been a big concern, and so that's really great to hear. I do want to open for the ambulatory care pharmacist. Does any of the panel members feel that they see an expansion of services or any changes to what they're offering based on these new billing regulations?
I know in my position, again, I would love to help with our controlling blood pressure and improving A1C measures for population health and our value-based contracts. And again, that's something that's really been slow to have a uptake. So I think, again, potentially utilizing that CPA and being able to bill, again, this is in that FAQ document from DMAS as well, but being able to bill some higher incident 2 codes up to 99213 might improve the value proposition there. And obviously that usually piques more interest. So that's something that in my particular position that I'm hoping, again, pharmacists across UVA are already providing some of these services. So I actually also wanted to touch on something that Dr. Gouveia mentioned is like potential revenue. That's something I might have heard this originally from Dr. Woods as well. So I'm definitely not taking credit for it, but tracking what you're doing, even if you're not billing yet, but you're providing the services that potentially could be billed for. So you can be like, this is the money, as she said, that we're potentially leaving on the table. I think that's eye-opening for a lot of stakeholders as well, that we're already doing it. We're not bringing in revenue, but this is the revenue that we could potentially be bringing in. So even if someone is already performing those services and really trying to drive the point home of we would be able to help the health system in general, that is a way that you can do it as well to, again, further in, again, peak interest, money talks. Outcomes are very, very important, but money usually talks.
And it's very new. So I think in 6 months, we may have more answers to hopeful expansion. But if these programs are successful, especially with the higher level and send two billing codes, we can really find that it is sustainable to have a pharmacist if you have a high level or a high amount of patients with Medicaid at your institution. So it is a little payer dependent, but there are a lot of opportunities with billing and covering at least pharmacist time and salary. So we'll see. But the future is, I think, going to be bright on that. I
Yeah.
do want to talk about credentialing, and specifically with the MCOs and Medicaid. So, for audience members, when you start billing for Medicaid, there are kind of two processes that you can do this with. Statewide protocols, where you bill under the pharmacist national provider identifier, and then collaborative practice agreements. Collaborative practice agreements, DMAS has asked pharmacists to bill under the provider that you work with. So if you're in a clinic setting and you're using CPAs, you do not have to get credentialed with Medicaid and with all the MCOs in Virginia. And I don't know exactly how many MCOs we have, but there's a handful of MCOs in Virginia that you would try to get credentialed with. But if you're using statewide protocols, so this is most often in our community-based setting, but it could be also in a clinic-based setting, you do have to go through a credentialing process before you can start billing for Medicaid. Keep in mind that credentialing is something that all other providers have to do. So this is not something that's pharmacist specific, but it is new for pharmacists. So it has been an adjustment, and pharmacists are not typically entwined in those processes yet. So there has been a change, and we're getting through it. So I definitely want to hear Dr. Flagg, and I know you're working through the credentialing process, and Dr. Govia, you've worked through some credentialing processes, and you're doing some more. But could you tell us a little bit about that process in Virginia and any recommendations that you have for the audience?
Or I can start. So we at Buford have really been utilizing our medical billing company. So they had a package where they would help us through that process, kind of do it for us on our behalf, and walk us through the steps. So first you have to apply for Medicaid as a whole. Okay, let me back up a little bit. So first getting you set up. So we have to go through CAQH, kind of put in your information, put in your credentials, hence the credentialing process, like verifying that you are qualified to do the services that you are providing. So some things that are needed for that, your pharmacists need to have an NPI number. You need to show your, oh my gosh, the word is blanking. Your liability insurance, and then putting in all of your credentialing through this CAQH profile. Once that is all done, you apply to Medicaid as a whole. And then from there, you still need to reach out to each individual MCO to get credentialed and obtain those contracts. From there, you can start billing those individual MCOs. And the part that is most difficult is usually when you're reaching out to those individual MCOs, they have a lot of different requirements, things that they're asking for, and all of them are a little bit different. So really working with our medical billing company, making sure that we're giving them everything that they need in order to reach out on our behalf to obtain those contracts. So that was a very broad overview of kind of that process. And what was really hard for me just starting out and getting into it is a very long process. And I was not very patient in the beginning. I've become more patient since starting this process, but just kind of knowing that up front. This will take a very long time. On average, they say very, very fast is like 3 months, and that seems a little crazy to me. But 3 to 6 months to kind of finish that whole process, start to finish. Um, so that was very, very eye-opening. So just being aware of that upfront. And with that, if you are going to be utilizing a company, if you're not going to try to do this yourself, you're also probably paying for this company for their time. So is that investment worth it for the time that it's going to take? So those are all things to consider. Do you want to invest in this company to do things for you? And that frees you up to do some of your other cash-based services, which is kind of that's the route that we took. Um, or if you don't really want to invest quite yet, you may want to just use them just for the medical billing piece after you've gone through that credentialing process yourself. So, you'll have to see what works best for your company. And are you doing enough, clinical services right now to kind of pay for that upfront? And luckily, we are at a good place in our pharmacy that we're able to do that.
Yeah, that's extremely helpful. I've heard a lot about both successes and challenges with getting credentialed, and we would just like to say it's worth the process. It's worth it if you have the patient population, you're able to do the services. It's worth the time, but other providers and big health systems may have more resources, whereas a pharmacist, especially like an independent pharmacist, may not have. You may have to pay a team to do that. So just keeping that in mind as you're navigating through the process. And I do think it's valuable information always to say, let's be patient and get it right. Because if you have to go back, they will reject and you will have to go back and fix things. So unfortunately, patience is a big thing. So, Dr. Govia, did you have anything else to add? Oh, and Dr. Flagg, there's a comment in the chat I'll refer you to. You can message them directly or let us know. But Dr. Govia, did you have anything else to add about credentialing?
Yeah, so everything that she described is essentially what you would have to do. On our side, though, the only difference is that we do it through delegated credentialing. So we essentially establish the process for these are the documents that we need from every pharmacist. We have NPIs collected centrally, so we have our licensing and credentialing team that already have that information. We essentially create a software system that prepackages, completes the applications for them, sends off the information to them, whatever we need them to sign in those cases. And then we have a centralized team that is just walking through the same steps, but through a delegated credentialing process. So it just depends on whether you want to do it centrally or you want your pharmacist having to do it manually themselves. I think it's the main difference on our side. Just one other thing that I wanted to add, I know she mentioned CAQH provider, which is primarily for physicians. I met at APHA with a product, and I don't know if you guys are familiar with them, but you might be Pharmacy Profiles, which is an APHA solution, I believe. And their goal, my understanding is that they are working to become the CAQH provider for pharmacists, essentially. So being that broker that can hold all of the information that can support you as you are trying to get credentialed. So for those that may be looking for solutions, that might be an interesting one to pursue.
Great, thank you so much. All right, so we have about a little less than 20 minutes till we get to our Q&A session. And so I think we're pretty much on track. The next part, we definitely don't want to end with this, so it's at a good spot, but there have been barriers. So everyone has put in the work to either start the process or become successful with the process. So maybe Dr. Lennon, what were some of your biggest barriers you had to overcome before being able to start billing?
Yeah, so I think for us, it was really working with our compliance team. Again, They were very helpful, but unfortunately just hadn't worked with a pharmacy team before. So they understood a lot of medical billing practices. And, an example of one of our barriers was having them understand like pharmacy residency versus medical residency. So they were very concerned about pharmacy residents being able to bill for services and can they see patients independently and things like that. So it was really just a lot of education about pharmacy and how we're licensed and again like the types of services and I think John had mentioned this before too, but really understanding that like scope of practice and billing are separate issues that sometimes merge together. So we had to do a lot of explanation about pharmacist scope of practice. And I think one thing that's nice in the state of Virginia is it is much more broad than some other states. So I came from New York State originally, and I would say comparatively, Virginia has a lot of flexibility. But I think sometimes the problem is that when things aren't written down specifically or not delegated to such a high level, then it's also hard to prove that that is within your scope of practice. So we had some challenges with that we had to pull resources from APHA or from ASHP, things like that, to kind of showcase what the pharmacist scope of practice is, and then also what is a collaborative practice agreement and what needs to be involved in that documentation. So a lot of our barriers really mostly lied with like the compliance team and just educating about pharmacists um, in that regard. And then I think from our standpoint, we were already doing a lot of the documentation. We had referrals in place. So, similar to what some other folks mentioned, like do the work early so that when it's time to start billing, it's already there. So we didn't have a lot of barriers with that, so to speak, because a lot of us had billed at other institutions and we're kind of familiar with that workflow. And then again, as I mentioned, some of the reporting aspects, I think where we're really struggling is there's a lot of adjustments happening. So they show up as like separate line items in the reports, and it's oftentimes really complicated just to get a final number about this is what the code we built for and this is what the ultimate reimbursement was, because there's many separate line items that are showing up, whether it's patient payment to the clinic or adjudication within the insurance company. So that's some of the stuff that we're still kind of working through in order to get kind of the big picture. I would say, again, early on, just making sure that you have a stakeholder on your team or a physician champion on your team that's really advocating for pharmacy is really helpful. I was very fortunate to have that in my clinic. And when I was brought on full time, my physician champion was the one who really showcased, the things that I could do, but also showcasing the time and resources that I was saving the physicians on our team in terms of opening up more patient appointments on their schedule, having some more bandwidth to answer the higher complexity, and then also being able to delegate some of the tasks to myself. So that was really helpful in bringing in pharmacy services originally. And that's kind of where we're looking forward to expanding at Inova is we traditionally had an ACO model, an accountable care organization model, where we were very focused on patient outcomes and metrics and things like that. And that's all still in place, but moving forward, we're trying to now do more of like the billing and the numbers and showcasing actually the revenue that pharmacists can also bring in so that we can expand into some more of the specialty clinics and primary care as well. So I think, those are the biggest barriers that we ran into. And, like everyone has said already, working with other folks in the state of Virginia, working with some of the professional organizations had a lot of really helpful resources too. So that's kind of where we were able to move things along and get the ball rolling.
Thank you, Dr. Lennon. I guess one question that has come up to me in my discussions with other people, and maybe you can comment on this since I think you've been doing it the most. Have you been asked to change the way you practice based on being able to get paid for more services? So I guess what I'm trying to get at what I'm trying to get to is in a fee-for-service model, and some of the advanced practice providers have really been asked to see a ton of patients. And traditionally, pharmacists, we're really focused on quality and improving outcomes. And so have you had any push to move away from that and go more into just seeing as many patients as possible to generate more revenue?
Yeah, I think that's a really important point. So I'm fortunate in my clinic that hasn't come up because we are specialty. The metrics, so to speak, aren't necessarily as clear as like a primary care model. So in residency, when I was in primary care, it was very clear, like A1C is under 9%, patients with diabetes on a statin, that type of thing. I would say that is not as outlined in our focus. So I'm fortunate and then I have not, but at the same time, I recognize that my salary is being provided by my clinic. And so I am trying to be very mindful of that. And just like Dr. Woods was able to really know where the numbers are and kind of know what codes to bill and what is really important for that service is where I've been trying to focus a lot of my time. I will say one of our other pharmacists within our health system, there has been much more of a push for her because again, they're paying for her salary to see many more patients and also expand some of the services that she's offering. So I have been able to, again, work with her and she's in primary care. So thinking about like annual wellness visits, thinking about CGM implementation, not only like the education piece of it, but also interpretation and trying to follow up with those patients regularly so that you are billing those codes as frequently as possible and as frequently that makes sense for the patient as well. So there has been a little bit of push from some of the other clinics within our system. And I think as we continue to expand this model, which is billing incident to the provider, that will continue to be a focus. And so I think we're going to have to be very cognizant and mindful of what is bringing in revenue for us so that we are not terribly overburdened with seeing a ton of patients per day and preventing burnout and things like that, but also trying to, again, get the revenue that's on the table, so to speak, so that we can continue to show our value and show that the salary that they're paying us is something that's important.
Yeah, I think that is a concern, and I think that is something to talk to leadership about early. But definitely want to open up to other panel members about barriers, or have you had any discussions? Has your practice changed, or do you expect it to change based on being able to generate more revenue?
I'd say for my end, we had our barriers would be primarily what do we do? Not many people understand, especially in just what ambulatory pharmacists are and, the impact and the kind of care that we can give. So my team and I, we actually have, it's a running joke, but we have a living PowerPoint, if you will, because we often have to bring this back up. Because I'd say, I won't say it's often, but, I'd say at least twice a year, there's usually someone either from leadership or another department that if we have an ask, they don't understand why we're asking. So we have to explain to them, hey, this is what we do. This is what other ambulatory care pharmacists are doing around the country as well, so that they understand that this is not something that we just, have this novel service line just exclusively at our health system, that this is what's happening in the state, this is what's happening nationwide, and this is the ask. So I do also highly recommend to have something like that, almost like if, for us, since there's three of us and we have a lot to share, it's a PowerPoint, but almost have like an elevator speech or an elevator document, if you will, to have ready so that when you're asking for something or you're expressing these service lines, and you may get well, why do you need this? You can explain, quickly without having to scramble. So it's very helpful to have and for us to have to update on a regular basis.
Thank you. Dr. Govia?
Yeah, I think, we mentioned a lot of the challenges, I think, throughout the session around contracting and credentialing and all those things. So I think those are, without, overstating those. I think for us too, and I started to mention it earlier, it's that patient awareness piece. So in, these services, it's kind of a new area. How do you ensure that the patient understands that they can come to the pharmacy to receive those services? Very similar to when immunizations started to be delivered in the pharmacy space. Now we see that change, right? And we've seen that those immunizations have really now, for adult patients especially, have moved into the community pharmacy. But beyond that, the awareness piece, there's also, with the contracting space, for us in our setting, because we have an open general population that comes to us, we market the service, talk about it, but then when they come to us and they show us their insurance, we may not be contracted with that insurance. And so, having having a conversation, an elevator speech, to your point, Dr. Woods, of, I'm sorry, we don't accept that insurance here. And so it could be really confusing for the patient population, as well as difficult for the pharmacy staff to have that conversation with the patient, but really being prepared for that and not being afraid to offer the service just because you know that there's going to be some differences along the way. So I would say that's a big one, I think. And then in terms of the change management, I think we've seen, because of the expansion of services, in our pharmacies, we have a range of pharmacists that have been practicing for a very long time. And then we also have new grads that, are really excited to provide these services in the pharmacy. Ambulatory care was kind of my goal to go into when I graduated school, but there's not really a whole lot of places that have roles for clinical pharmacists. And so we are essentially trying to merge that gap in the community pharmacy space, where we are providing some basic services and really trying to close the gap between the shortage of primary care providers. And so ensuring that we are getting our pharmacists to understand the need and why we are going into that space. For those that maybe say, well, I went to pharmacy school because I didn't want to have to immunize. I didn't want to have to put a needle in the arm. I didn't want to have to do these things. But really setting that expectation that this is where the pharmacy profession is going. And if you're wanting to practice in a community pharmacy space, this is essentially what it's going to be expected and required of you to continue to be competitive in that space. So I would say that's a really big part of it. And also, I think somebody else mentioned earlier, there's the liability part of it that a lot of us and our legal teams, obviously raise awareness around that. But then there's also the pharmacists who may be hesitant because they say, well, I don't want to do that because now I'm opening the door to risk, right? And exposure, for example, with testing and treatment. And then having really some very basic and real conversations with them about, well, technically speaking, you're dispensing antibiotics all day long, and you're not wearing a mask whenever you counsel those patients. And so you have no idea who might be coming into your pharmacy and what sort of exposure you have, right? And in terms of the risk and the liability, and I could make a mistake, well, we can do that every day if we don't pay attention to what we're doing when we dispense medications, right? The day-to-day thing. So I think it's just bringing it back to really real terms and making sure that there's an understanding of that. And then just on the billing side, one other piece to call out is, as you're standing up your programs, if there are specific plans that you're trying to bill against, it's making sure that you're building your program to be able to build those ICD-10 codes that they accept. An example for us is we offer molecular testing for flu, strep, and COVID, which is a higher quality, confirmatory type of test. But Medicaid does not reimburse for molecular testing. They only reimburse for antigen testing. And so, ensuring that you're billing for the right products and that you're building your program to sustain the billing that you're expecting to get on the other side. And then just the last call out, I think, on the outcomes piece, I love Dr. Lennon talking about it and Dr. Woods. I think the outcomes, yes, you look at direct revenue that is coming in from those services, you follow it through, et cetera. But also we do a lot of pre-screenings for blood glucose, cholesterol, and blood pressure, and ensuring that you're tracking, we track those as well. So even though we're not billing for those services, we still track them, because at the end of the day, we need to be able to demonstrate how many patient lives you are touching. And we do a lot of identify a lot of patients who are undiagnosed through those free screenings oftentimes. And so we have to be able to advocate for our profession to be able to say, this is how many times we have been able to identify undiagnosed patients earlier on than they would have. And so what does that mean for the healthcare spend as a whole, for our country or for your state? And I think those are other ways that you can demonstrate the value of what we are doing.
Thank you so much. I'm going to, based on Dr. Woods and Dr. Avila, I'm going to put a plug back in for Dr. Salgado's presentation, where we are trying to recruit people to do some research in these areas. Having published data that these things happen is important. So CPPI is a resource if you're interested in research, but also if you have questions, we would love to help in any way that we can. So good points, excellent points, and then marketing is still going to be really big, especially in those community-based settings. So thank you, everyone. All right, so we're getting close to our Q&A session time. We've touched briefly on some resources, but does anyone have some really good resources they want to touch on just very quickly on that were helpful for as you're walking through this process? What did everyone use to implement?
I'd be happy to share a little bit on that because, again, when I was at Augusta Health, I did a ton of research on this. So, obviously, state level resources, that DMS FAQ document is really, really helpful to understand the overview of, again, like you said, Dr. Buchheit, is if you have a collaborative practice, this is what you do. If you're using statewide protocols, this is what you can do. Again, state associations are helping outline that credentialing process, which is really helpful, but also knowing the legislation, both at a federal and at a state level, I think is really helpful. Again, because I think that's where some of the confusion comes that a lot of the panelists have talked about is other stakeholders don't understand what pharmacists can do, again, at a federal and a state level. So I would be really up to date with that and know how to stay up to that. As Dr. Buchheit mentioned, there was just an update to CPA legislation in Virginia just recently, like within the past month or so. So you need to know how to stay up to date on that as well. And then also national resources from our state or our pharmacy organizations. ASHP has some great general resources for incident to billing. Avant Institute, I know Dr. Woods is a really big fan of them as well, that they have a lot of resources developed for collaborative care services as well. And again, our work group, I think, is a really great resource to shamelessly plug it because we try to compile a lot of those resources in one place for members.
Great. Do you want to take a second and just tell us about the practice advancement group? I know I mentioned it earlier, but I think the audience can tell that some of us may have talked in a group meeting, maybe every 2 months, about billing and payment and advancing pharmacy services. Do you want to put a little plug in for the practice advancement group?
I always do. So again, this group is providing resources as well as connections for any pharmacists in Virginia. Again, it can be community setting. We do have a little more emphasis on ambulatory care pharmacy because that's where we've seen a lot of barriers. And that's where we are getting together. I think it's quarterly now, but we still send monthly emails with clinical and legal updates, any type of events such as this. We're letting members know about that so they can attend and get the most up-to-date information from other pharmacy leadership in the state. And again, we're providing those connections so that maybe you have discovered a resolution to a barrier that someone else has, or vice versa. So we're really hoping to make that connection again to facilitate a united advancement rather than having pharmacists independently reinvent the wheel in every single health system or every single setting. So again, it's completely free to join. There's no registration. So we always really encourage you to attend meetings. If you're interested, you can email me. I'll put that in the chat and we can add you to our listserv for any type of those, again, monthly updates. And then there's a website that we have, again, where we try to create that repository of resources. You'll be able to access that as well.
And I can truthfully say that this is one meeting. I know we all have lots of meetings I love going to. Every time that they offer it, I learn something new at those meetings. So they're very comprehensive. Any other resources or things that panel members found helpful as they were implementing the services?
Yeah, I think, and Dr. Slack kind of mentioned it, but I think it's, looking into the documentation piece. I think that's really a big part of it. It could be really easy to forget to document, a certain requirement. And so whether you're doing it on paper format, making sure that you're creating something that is really easy to understand and implement, or look at digital options. There are several companies out there that provide sort of protocols that you just work through, or workflows, they call them, depending on the services that you're providing. And so exploring, what are the possibilities and what is the right solution for you in that setting. But, the old SOAP format, right? And it just open kind of space could leave a lot of ambiguity. And then that's where you could get into maybe some challenges with collecting reimbursement on that if documentation didn't take place appropriately.
Good point. Okay, so at this time it is 9:47 I have on my clock. It is time for the audience Q&A. So please, if you have any questions, you can put them in the chat or you can raise your hand and we're happy to answer them. Again, we are happy to take questions from both community-based setting, ambulatory care setting, or if you're not sure, we're happy to work through that with you. So this is our time to give you some information. And as people are thinking of their questions, I may throw this one out back to Dr. Flagg. You mentioned there's some billing platforms that have been recommended, and there's resources to recommend those. Can you touch on that a little bit? Not have to be specific, but are there resources on if you're in a community-based setting, especially what kind of billing platforms, or where are some resources to get some information? Because that can be overwhelming not to know.
Yeah, so the ones that I put in the chat are companies that are recommended by CPESN, so for community pharmacies specifically. And CPESN has, reached out to those companies individually, kind of vetted each of those companies to ensure that they're doing things appropriately, that they are sharing their data with CPESN, just to make sure that that compliance piece is in place. So, and each of those companies are fairly different in what they're offering. So you may need to interview each one of those, just to kind of see what they offer. How would that fit in with your workflow? What things don't they offer that you wish they did? And do they have any workarounds around that? And it'll be hard not to try each one out. But they usually have like a demo of their services, really great about answering all of your questions, really willing to work with you. And they're medical billing, so they don't get paid if you don't get paid. So they are really for your success. They want you to be successful. And so they will do what they can to make sure that they're getting those contracts, that those claims are going through. You as the pharmacy would still need to go back and make sure that those claims are actually going through. But as a whole, they're not getting paid unless you're getting paid. So I think those companies are a great place to start to see what they offer and how that fits in with your location.
Thank you. And for those that are clinic-based pharmacists, remember we're billing under, if you're using CPA, billing under the provider. And in 2019, we started billing Medicaid just through level 1 codes. That's all we were allowed to bill, and CGM codes. So as soon as we could start billing at higher levels, it was a very easy switch. You just change the codes and document and bill appropriately based on your level of service. So it's a little bit easier in some ways if you're under a CPA, because if you're in a clinic, the payment systems are already kind of set up. But this is a really important process if you're doing statewide protocols and you're billing under the pharmacist MPI. It looks like we do have a question for Dr. Woods. Dr. Woods, are your billing reports generated within the Epic electronic medical record?
Yes, thanks for the question. Yes, they are. They are billed through and then generated through Epic. So when I reach out to the billing team, they export it. There's a password protected, so that I can get the information. And then from there, I extrapolate out the applicable data that I need to have so I can present and just to have my own records. Thank you for that question.
We have about a few minutes left. Dr. Salgado is going to launch some questions at the end here. So as we have just a couple minutes left, maybe we can give each panel member give 30 seconds on what advice would you give to pharmacists who are beginning to explore Medicaid billing options? So if you had a 30-second speech on that, what would you recommend? And maybe Dr. Lennon, can we start with you since you're at the top of my screen here?
Sure. I think generally, if you are practicing in a clinic, trying to get a collaborative practice agreement really expands your scope of practice, allows for a little bit easier implementation of some of these billing practices, and can really help showcase and allow you to show to the team the types of services that you can offer. I think professional organizations have a lot of great resources. So that was a question that was asked, but both ASHP and APHA, I have found billing documents and helpful tips and tricks from them, as well as ADCES if you are looking to become involved in any sort of diabetes care in the CGM billing.
Great, thank you. Dr. Govia, what advice do you have?
Yeah, I would say, so first identify again, if you're looking to build Medicaid, what services are covered. I think another important part of kind of that business plan preparation piece is what are the services that would be most successful in my area? What are the needs of my community? Because every, city may have different needs. And so you definitely want to support your community, I would say, with services that are important to them. And just start today. I would say, somebody put in the chat that it's really intimidating. It seems like a really big process. And yes, we've talked about it takes a really long time, but if you don't start, then it never happens. So I would say start today.
And you're not alone. Everyone's trying to figure this stuff out, so don't feel like you're on your own. Everyone's doing it. So good advice. Dr. Flagg?
Yeah, I think something that was really helpful for us, which was mentioned before, was, just starting those documentation changes. I think that was a really big thing for us. And really utilizing the colleagues who have kind of done this before you. So, our residency program, we meet every week. So we're, very comfortable talking with each other. And I've picked everyone's brains about what to do, who to reach out to, just asking those questions. And more often than not, your colleagues are more than happy to talk to you about what they've done, what they ran into, to try to, to help you kind of avoid the mistakes that they had already made. So utilize your colleagues is a big, big, big tip, which I highly recommend. I pick everyone's brain if I can.
I agree. Mentors and colleagues are helpful. Dr. Ray?
Yes, so I have four main pieces of advice. So do your research, know the legislation, look at the FAQ document, understand enrollment and documentation requirements, connect, as other members have said as well, connect with pharmacists, attend these types of sessions so that you can learn from other pharmacists doing this. Find a stakeholder champion. Again, a provider usually provides a lot, their voice holds a lot of weight at institutions usually. But as Dr. Woods mentioned earlier, revenue cycle, they have a champion there, and that's been really helpful for them as well. So finding some type of stakeholder champion and then track, again, even if you're not doing this yet, billing yet, but you're providing some services, look at those clinical outcomes. Did adherence or patient outcomes improve? Did you reduce ED utilization or admissions? Some operational metrics you can look at is provider and patient satisfaction with the services, time to next new visit or third next new visit for your providers as well to try to open up their schedule. And again, as I mentioned earlier, that missed revenue, what you could have billed. And also maybe potentially tracking those potential RVUs, because again, if you're billing incident to, those RVUs are going to the providers, which they also like usually. So
Dr. Ray,
making sure.
we're running low on time. I'm very apologize for interrupting.
No, you're good. That was
This
it.
is what the practice advancement group is for. I want to give Dr. Woods her 30 to 60 seconds, and then Dr. Salgado is going to launch two questions because I think this session is going to end. So go ahead, Dr. Woods.
Okay, really quick. I think everyone said everything very well. The last piece I'd say is just to beef up with as much knowledge as possible, so that once you present this service line, you have your numbers, you have your champion, and you're speaking to leadership. You're going to get a lot of questions around why and technicality pieces. The more that you're able to speak to those clearly, the better it'll be digestible for them. Just like how we are, we're human beings. If you seem hesitant, they're going to get hesitant. So just try to be as knowledgeable as possible. Kind of go back to your regular pharmacy school. I don't know, but I can get back to you. Just try to keep that confidence with you when you're selling yourself up. But I think everyone else said it very, very well.
All right. Thank you. Thank you, panel members. You all were fantastic. Dr. Salgado, I'm going to give it back to you.
Yeah, thank you everybody for your contribution. John, you've done an amazing job moderating, and everybody has been providing such rich experiences, and I'm sure that the attendees benefited from all of this. For those of us remaining on the call,